Dr. Shaima Abdel-Sattor, Dr. Khaled, and all the scientific committee for inviting me in this very honored Congress. وإحنا طبعا we are very much interrelated with pediatric radiology department. My talk will be about phenotypic clues to inborn errors of immunity. The components of my lecture will include definition and classifications of inborn error of immunity, clinical phenotypes of IEI, system-based phenotypic clues to IEI, and summary. I have none to disclose. Starting with an introduction for this disorder, inborn error of immunity represent defect in the immune system caused by monogenic germline mutations, means they are inherited or occur as de novo, but they are germline mutation, and subsequently results in weakened and or dysregulated immune defense, and both coexist. They are known to affect 1 of every 1,200 to 2,000 individuals, and the frequency and the prevalence is increasing because this is estimated to be much less than the real prevalence because of under-recognition of this disorder. Therefore, the magnitude of the IEI frequency and consequences mandate that all healthcare providers identify the possible presentation of IEI. So there is a society, the International Union of Immunological Societies, like every 2-3 years, they update the classification of inborn error of immunity based on the detection of de novo mutation and gathering the phenotypes together and the genetic basis. So the broad categories of IEI include immune deficiencies affecting cellular and humoral immunity, which is combined immune deficiency, and combined immune deficiency with associated or syndromic features, predominantly antibody deficiencies, and disease of immune dysregulation, including hemophagocytic lymphohistiocytosis and inborn error of immunity with a specific Epstein-Barr virus susceptibility, and syndromes with autoimmunity, congenital phagocytic defects, whether number, function, or pose, defect in the intrinsic and innate immunity, autoinflammatory disease, which are mainly characterized by systemic inflammation rather than increased susceptibility to infection, complement deficiencies, and lastly, phenocopies of IEI. Phenocopies of IEIs means they are either acquired disorders mimicking inborn error of immunity or just like somatic mutation, not germline mutation. So coming to the clinical phenotypes, the clinical presentation is highly variable, and they are usually various combination of increased susceptibility to severe, unusual infection, including opportunistic infection, bone marrow failure, malignancy, autoimmunity, antibody-mediated, even they are deficient, but they have some sort of autoreactive escaping B or T cell causing production of abnormal autoantibodies, or autoinflammation triggered by the innate immune dysregulation, atopy, neurological disorders, and lymphoproliferation. And it is very important that high index of suspicion remain the key for early diagnosis because we don't have newborn screening for IEI. Therefore, early and prompt diagnosis is essential to avoid high morbidity and mortality associated with late diagnosis. And for this, for the general practitioner and non-pediatric immunologist, the Jeffrey Model Foundation listed 10 warning signs helping to pick up these patients in clinical practice, like 4 or new ear infections within a year, 2 or more sets of pneumonia within 1 year, need for prolonged antibiotics with clear effect, or need for intravenous antibiotics, like fungal infection persistent, need for hospitalization, family history of established diagnosis, or previous history of sibling death. So going to the system-based phenotypic clues, according to the organ involvement, our colleagues, pediatric radiologists, play an important role in the evaluation and diagnosis of IEI, and familiarity with the imaging appearance of characteristic organ or system involvement is a key, as identification of distinct patterns by a radiologist may expedite diagnostic workup and treatment. So if we start with the respiratory system as infectious disorders, patients tend to have chronic sinusitis, pneumonia, mainly by the virulent organism and as well as by opportunistic infection, bacterial and fungal, including Pneumocystis cerevisiae and CMV pneumonitis. They tend to have nematocele-like certain group of hyper IgE syndrome, lung abscess, cavitations, and empyema. But they tend also to have non-infectious immune-mediated disorders like interstitial lung disease, granulomatous lymphocytic interstitial lung disease, lung granuloma, lymphoproliferation, and even lung dysgenesis and abnormal lung development. And this is very important that both can occur hand in hand, and we can differentiate because even patients with IAI and they have weakened immune system, if they develop immune-mediated disorder, there should be tight balance how to use immunomodulatory and immunosuppressive in the face of the underlying immune deficiency. And both can end in long-term complication like bronchiolitis obliterans, bronchiectasis, pulmonary fibrosis. What about if these patients have some sort of difficult pneumonitis that can be lately diagnosed by PCR techniques like the Pneumocystis cerevisiae pneumonia, fungal and CMV pneumonia? The pediatric radiologist may be the first provider to suggest the underlying causative agent of the pneumonia. And this is essentially critical to guide the treatment because we have all that the CMV pneumonia need a specific antiviral against cyclovir and for long-term duration, as well as for the Pneumocystis cerevisiae, it needs a long-term treatment with the sulfonamide high dose. This is, and I will not go through the radiology. I just give examples for how patients presented to us. Like this patient, this is his first initial presentation, a 3-year-old with possible card9 deficiency. It is an innate inborn area of immunity that predisposed to serious disseminated and invasive fungal infection. And by this plain chest X-ray and the tachypnea and hypoxemia, we considered that it may be Pneumocystis cerevisiae pneumonia, and this was his chest, CT chest, wide list of differential diagnoses. This is a 36-month-old patient with chronic granulomatous disease, which is a defect in the phagocytic function, predisposing the patient to fungal infection, bacterial infections, and granulomatous disease of the lung as well. And this is a 4-year-old patient of his kid. This patient is normally the severe combined immune deficiency does not survive for this long duration, except with some sort of certain hypomorphic mutation. And eventually the patient caught severe infection as it, with time, get contact with virulent organism in the surrounding environment. And this patient unfortunately died. And we do not, the parents got some sort of denial that the patient exists for a long time, so he can continue his life like this, and they don't listen to the compelling advice that he should be transplanted. And this is an 18-month-old kid with high CMV PCR reaching 2 million, and eventually he died as well. So what about imaging of the thymus that can be detected while we are imaging for the chest? The thymus is, as we all know, lymphatic organ, which is responsible for T-cell immunological function, and it grows considerably in infancy. Thymic aplasia or hypoplasia is a part of the DiGeorge syndrome, which is a form of inborn T-cell immune deficiency with certain dysmorphic facies, and as well they have parathyroid hypoplasia, predisposing this patient to neonatal hypocalcemia. So, and it is as well, there is some sort of reduced size of the thymus in patients with severe combined immune deficiency with almost T-cell null function. And imaging of the thymus is very important for us as a pediatric immunologist. We're just trying to pick its size through the chest X-ray. And if we are suspecting, we ask it more for ultrasound and computed tomography. And this is very essential for us to comment on the thymus. What about hepatobiliary and gastrointestinal systems, the infections, including liver and splenic abscess? And I would like to thank Dr. Shaima. She is getting for us many findings for these patients because this is very important to tailor the antibiotic regimens. And further, for preparing for transplantation, these patients should not have active focus of infection. Hepatosplenomegaly, infectious enterocolitis, peritonitis, ascites, and we also have a list of non-infectious disorder like sclerosing cholangitis, and this is very appreciated in a patient with hyper IgE syndrome. You find the patient with severe refractory eczema and stunted growth, and these patients, they might have sclerosing cholangitis without any laboratory or clinical symptoms, but getting to the abdominal sonar, we found dilated biliary radicals. Liver and splenic granuloma, and as I shortly said, we have to differentiate between immune-mediated granuloma or liver abscess. Inflammatory bowel disease, and this is very much appreciated in patients with inborn area of immunity, autoimmune enteropathy, like patient with LRBA deficiency, some sort of Tregs immune dysregulation, pancreatitis, hepatic veno-occlusive disease, Budd-Chiari syndrome, malignant and non-malignant lymphoproliferation, and ending this disorder can with liver cirrhosis, portal hypertension, and liver cell failure. So coming to the nervous system, patients are susceptible to meningitis, encephalitis, brain abscess, and rarely progressive multifocal leukoencephalopathy. And non-infectious disorder, a very long list of immune-mediated disorder like acute, and as Dr. Rania beautifully demonstrated for us, acute disseminated encephalomyelitis, acute hemorrhagic encephalitis, and this is a recent patient with veno-occlusive disease and immune deficiency, and he got acute hemorrhagic encephalitis, and instead, and in spite of receiving the exact protocol for the disorder, the patient is unfortunately non-responsive at all. Cerebral vasculitis and aneurysm, and this is also with the hyper IgE syndrome, focal demyelination necrosis, cerebrovascular accident, neurodegenerative disease like in patients with ataxia telangiectasia, intracranial calcification like patients with Aicardi-Gouttiere syndrome, which is one of the interferonopathies systemic autoinflammatory disease, cerebellar hypoplasia like in patient with ataxia telangiectasia, partial callosal agenesis like in patient with DiGeorge syndrome, colpocephaly, and brain tumors. So what about the hemophagocytic lymphohistiocytosis, and why we specifically concentrating on the isolated CNS hemophagocytic lymphohistiocytosis? Because it has a very long list of differential diagnoses, and isolated HLH is commonly missed and treated as a picture of a touch of viral encephalitis till the patient has got brain atrophy and lost his life. So the MRI finding, I will not go for the image, I'll just go for the findings. Could be in pediatrics, they found it to be distributed in two categories, like significant parenchymal disease, which has 3 sub-patterns, multifocal white matter lesion, brainstem predominant disease, and cerebellitis. And the other pattern is attenuated imaging phenotype with more non-specific findings that tend to be more in younger individuals. Chronic changes such as atrophy and calcifications are reported on the long term, and we have patients that have been treated 3 times as a part of encephalitis. Why encephalitis recurrent? It should be referred, these patients should be referred to a specialist. Why encephalitis 3 times and every time to receive IVIG? Till she come to us like cerebral palsy, like she is quadriplegic. Aicardi-Gouttiere syndrome, by CT, we can find the calcification in the basal ganglia, thalamus, paraventricular white matter, and it could be dense or tiny. And the MRI will find like high signal intensity in the frontal temporal lobe, atrophy eventually develops, and these patients are liable as well for cerebral vascular anomalies like aneurysms or stenosis, and interestingly, moya-moya pattern encountered. The musculoskeletal system, including the infectious disorders, septic arthritis, osteomyelitis, and intramuscular abscesses. But very interestingly, this osteomyelitis could be multifocal osteomyelitis, autoinflammatory disease affecting the bone. And this is very important, like this in our patient. He was referred to us as a part of immune deficiency with the infected osteomyelitis process, but the good general condition of the patient and the negative cultures led us to do whole body MRI, which eventually leads to discovery of multifocal spots of osteomyelitis, diagnosing the entity of chronic multifocal osteomyelitis. These patients are as well liable for chronic arthritis and immune-mediated mimicking GIA, or the classic picture of juvenile idiopathic arthritis. The presence of a skeletal dysplasia with the patient's stunted growth and increased frequency of infection should lead us to, or presence of autoinflammation or autoimmune disease should trigger or raise the index of suspicion at the radiologist to refer and advise to be seen by pediatric immunologists so as to thoroughly evaluate the patient and know what's possible underlying immune defect that gather all these features together. Patients with IEIs, certain patients have some relative contraindication for X-ray imaging procedures. These are typically the chromosomal breakage disorder, ataxia telangiectasia, Plume syndrome, Nijman breakage syndrome, Cranionius deficiency, which is a part of a severe combined immune deficiency, and Fanconi anemia. So why I put this? Because a patient with ataxia telangiectasia, she went to ENT surgeon, and she has otitis media, and he asked for, maybe he doesn't know the disease, but he should know, and he referred the patient for radiology center, and she did CT mastoid and paranasal sinus. So I appreciate from the pediatric radiologist to communicate with the clinician, telling him that this patient should not undergo CT and advise him by the proper imaging modalities that should be done. So in summary of my talk, IEI are monogenic disorder with highly variable clinical phenotypes that require high index of suspicion to allow early and proper diagnosis. Phenotypic clue to IEI includes severe and or unusual infection, failure to thrive, history of similar condition or sibling death, unexplained CNS inflammatory process and or intracranial calcification, systemic or organ-specific autoimmunity, autoinflammation. And the major role of imaging features of IEI in guidance, the diagnosis, and management of IEI emphasize the importance of the familiarity of the radiologist with them. And the good communication is essential between pediatric immunologists and radiologists to help choosing the most appropriate imaging procedure and interpretation of the finding in the context of the clinical phenotype of the patient. So at the end, I would like to thank you for your attention, and I would like to acknowledge the Pediatric Allergy, Immunology, and Rheumatology team founded by our late Professor Yahya Al-Gamal, and thank you very much.